Boleh nampak slide saya ke?
Oh, ya betul. Boleh kita start sekarang?
Boleh nampak slide saya ke?
Oh, boleh nampak. Assalamualaikum warahmatullahi wabarakatuh, and a very good morning to all. Let's begin our session today with a microphone al-Fatihah. Welcome to all the professors, assistant professors, doctor, officers, brother and sisters. Welcome to our CME today. Before we start our CME today, I would like to remind the participants to turn your microphone off during the talk, and don't forget to register in all attempts for attendance. For medical practitioners, kindly fill in the Google form for CPD points. The Google form link will be given in the chat later. And also, please be informed that this CME is live streamed via Fastnet YouTube channel. If you have any questions, you always can type in the chat box, or you can interact with the speakers during Q&A session. Without further ado, I would like to invite our speaker today, Assistant Professor Dr. Abdul Malik from Department of Surgery, Sultan Ahmad Shah Medical Center at RIUM, to give his talk with the title Care and Complications of AVF. Doctor.
Assalamualaikum warahmatullahi wabarakatuh. Testing. Can the audience hear me clearly or see my slide clearly?
Yes, Doctor, your voice is clear and we can see a slide.
All right, okay. So thank you, Madam Chairperson. So my name is Dr. Abdul Malik Muhammad, and I'm one of the general surgeon from the Department of Surgery, IIUM, Kuliah Medicine. So for today, weekly hospital CME by SASMED IIUM, hosted by the Department of Medical Education. We chose the topic of AVF care and also the complication of it. I don't have anything to disclose for my presentation, but I would like to show my gratitude to my mentor, Assistant Prof. Dr. Ahmad Faizal Osman, for guiding me in preparing this slide. Okay. So as the introduction, to start off our discussion today, why do we need to talk about AVF care and complication? You can see from the fact, actually, the prevalence of CKD is increasing. Back in 2011, it was 9%, and it's almost double to our latest data that we have to 15.5%. And then the incidence of patients with end-stage renal failure also increasing, that they require dialysis. And we can see actually the number of patients with diabetes, the number one cause, the leading cause for ESRF also increasing in our country. And the data show actually Malaysia ranks among the highest for ESRF due to diabetes mellitus. And for those who doesn't know, and for those already know, actually the only available treatment for ESRF is renal transplant. Okay, so because of the number of donor for kidney in our country is lacking, dialysis remains the active treatment in about 98% of the patient with ESRF. And now in Malaysia, we have about 142 government hospitals with 14 health clinics that offer the service for dialysis. We have PD units, peritoneal dialysis unit that offer for dialysis as well. Actually, the vascular access actually initially meant for temporary measure for patients for the if kidney from the other patient or the other donor. But because the number of donor for renal transplant is not that much, now it become much more like definitive treatment for our patient until they met their maker. Okay, so what is the idea vascular access? Actually, the idea vascular access is access that can provide safe and effective therapy that enable the removal of the blood and return of blood via an extracorporeal circuit. So today we are talking about the AVF. Actually, we are talking about native access, the arterial vein fistula, and it requires proper planning because it has a high primary failure rate. Okay, so apart from the AVF, we also have the alternative for AVF such as graft, and so we have catheter. We have the permanent catheter, we have tunnel catheter. Okay, so I'm not going to talk about that today, but our main topic today will be the AVF, the arteriovenous fistula. Okay, so what is actually AVF? Patients do come to us asking weird questions such as what actually machine that we put into their arm, did the machine require battery, how long the battery lasts? Actually, no. We doesn't put any battery or any machine or any gadget inside the patient arm. Actually what we do AVF, we anastomose. We attach, basically the layman term, we try to take an artery, take an vein, then we anastomose it, we attach it together. So after this anastomosis, what will happen actually, this tunica intima with hyperplasia, and then the diameter of the vein also it will increasing, enlarging. So this is to prepare the vein for hemodialysis. Okay, so actually how do we select which vessel we want to do the anastomosis? What's the vessel actually? First, we select arms before the leg because it's more hygienic. Distally from the cradiocephalic until the basilic, using non-dominant arm because we don't want the arm to be active during if there is fistula there. And then the type of IVF that we have actually depending on what are the vessels that we anastomose. So basically we have brachiocefalic, brachiocephalic, brachiobasilic, and last one, if patient doesn't have any vessel, what we can do actually we put a graft, put a synthetic vessel for the dialysis. All right. Okay, so now we go on to the care and maintenance of AVF. So I will divide the care and maintenance of AVF into three parts, which is the access, maturation, and care, cannulation of the venous segment, the fistula, and last one would be the access, monitoring, and surveillance. So for access, maturation, and care, so what will happen after we anastomose a vein to the artery? These changes will lead to maturation of the AVF. Usually, the process will take about 6 to 8 weeks of the first creation. So after the creation, we will give instruction. We'll give some order to the patient on what will happen to the fistula, about the wound healing, how to care about the fistula, and the possible complication to the patient. And then what are to avoid during this procedure, during the time before we meet the patient again in our clinic after the operation. So we also will instruct the patient on self-examination of the fistula by palpating the thrill. The patient actually can feel the thrill, it's like in Malay, it's a gegaran, what happened to the fistula. And then, because usually this patient that underwent this procedure also have already established on dialysis. So actually, we also write a letter and instruct the HD nurse to examine the AVF during their dialysis session. So how to assess whether the fistula already matured? Actually, you can do a clinical examination by palpating the thrill, measuring the size, and also if we have the capability, we have the access to assess ultrasound, we will do ultrasound. And here in our clinic, in SOPD SASMED IUM, we do have ultrasound, and we always assess patient by ultrasound assessment. And we usually can use rule of 6 to assess whether the AVF already matured, which is usually 6 weeks after the creation. The size of the vessel around 6 mm. The distance of the vessel to the skin, the distance of the vein to the skin is about 6 mm. And actually, we would like to have about 6 centimeter length of the vessel for puncture for cannulation of the AVF. And the last one will be actually the flow of the AVF. We have actually 600 ml per minute at least for a good dialysis session. Okay, so actually the non-maturation actually is quite high, about 10 to 33% in brachiocephalic arterial fistula. The proximal one actually about 10 to 30%, and for the distal one actually is higher, because actually the distal one, the artery is slightly smaller than to the proximal one, so actually the incidence of failure is higher. If the patient during our assessment noted there is failure to mature beyond after 6 weeks, actually we have to assess the patient via ultrasound or angiogram to see what are the possible cause of the failure of maturation. Usually, non-mature AVF actually salvageable. We can do something about it, and out of that, 80% might be remediable via surgery or endovascular approach. And we do have the service here, both open surgery and also endovascular treatment. So what are the common causes for non-maturation? Could be stenosis, or the venous or arterial or anastomosis site, because they are, second, could be because of their large branches, competing veins that prevent the maturation of the AVF. And the last one, it could be because of it's too deep. The vessel is too deep. This one we might need to do the superficialization of the vein, bring the vein to more superficial side. Okay. Okay. The second thing, actually, I'm talking about cannulation and needling technique. This is very important. This is not for us per se, because we are not the one who cannulate the fistula, but this actually will see whether the AVF can be sustained for a long time or not. Okay. Usually there are 3 standard techniques for needling. We have the area puncture cannulation. We have rope ladder cannulation, and the last one we have buttonhole cannulation technique. And according to the guideline, both from the UK Renal Committee and also by European Society of Vascular Surgery, both suggest actually rope ladder or buttonhole technique. Sadly to say, actually in Malaysia, mostly we use the area puncture cannulation. So that's actually can say why our longevity of the AVF is less compared to other countries actually. So this is the picture of actually how rope ladder, buttonhole, and area puncture. You can see from my picture here, this is the A is rope ladder. Basically, you will alternate the puncture like a ladder. So in every visit of dialysis, we'll change the connection site. B actually is you puncture at the same site, both for supply and return for the blood. And C actually you create a tunnel. It's like a buttonhole, same site, but you create a tunnel towards tunnel in the skin and puncture to the vein. Really, this one first session you use sharp needle. After six session, when the tunnel already matured, you can use a blunt needle to puncture the vein. So it's either A or C actually is best for patient to ensure long-lasting AVF for the patient, right? Okay, so that's why our HDness, our hemodialysis play a very important role in our AVF care, because the patient with end-stage renal failure usually require about 300 needle incision per year. So you just imagine they need to be punctured about 300 times per year. So if we really didn't take a good care of the fistula, it will fail eventually. All right, and make sure during every session of dialysis, make sure you use the proper aseptic technique to prevent infection, because we do actually encounter a lot of patients with complications of infection. Okay, so don't take it lightly, because you are dealing with very delicate matter. So if you are a nurse that taking care of our dialysis patient, make sure you take this matter seriously. Okay. Okay, so last one with how do we actually monitor and do the surveillance for our vascular access. So patient on long-term hemolysis should have their vascular access monitored and maintained to minimize the failure, as I mentioned before. So early recognitions of failure can actually do a good thing to patient. We can recognize early the problem, and then we can do something about it. So if we able to detect early, we can salvage the fistula, and patient might not need second creation of fistula. So actually, the role of PSC is role by our hemodialysis unit. They have to actually do a proper surveillance and monitoring the patient during their session of dialysis. Okay. Okay, next, we'll go about the complications of AVF. To do it more systematically, I would like to divide the complication of AVF into immediate, early, and late. For immediate, actually, is actually that we encounter during surgery. During the surgery, what will happen? For example, bleeding because of injury to the artery, the vein, and also nerve injury as well, because we actually encounter quite a number of times actually nerve crossing the vessel, so we have to really take a good care of it and make sure we didn't injure the nerve. And then we have early. Early can be as early during after the creation up until 2 weeks, and then we have late complication of arterial venous fistula creation. Okay, we go one after. For immediate complication of AVF creation, bleeding, and also artery injury. So during procedure, actually, we need to ligate branches of the vein. Actually, vein, they have multiple branches. They have multiple tributaries. So to make sure the creation is such to ligate branches. So this vein actually can cause bleeding if we really didn't take a good care of it. And then the distal end of ligated vein, the vein that we actually want to anastomose, sometimes we try to get to the bottom of it, to the most distal of it, so we can get a good line. So during this time, there's possibility of the node that we created, we ligated the vein actually slip. So it can also cause a major bleeding as well. And then part of the procedure, we have to do arteriotomy. Arteriotomy meaning that we do incision, we do some opening over the artery. So there's possibility of injury to artery. Our aim actually to do arteriotomy on the superficial part only, but can it can be true and true injury if we are not taking a good care during the procedure. Okay, so if this happen, yes, arterial bleeding could be a very major bleeding, so it's very troublesome for us if it happen. Alhamdulillah, for me, I didn't encounter this kind of complication yet. I hope not in the future, inshallah. Okay, so next will be early complications of AVF creation. Okay, so the first one, same thing. Why? Actually, because all our patients that come for AVF creation, they are already in stage renal failure. So urine patient time for bleeding. So the possible source of bleeding can be, like I mentioned before, smaller branch or larger source. And sometimes this bleeding may require exploration. So patient might have to go to a second operation. And bear in mind that actually in patient that we created AVF, we have to avoid compressive bandage because this can alter or compromise our fistula. So that's why it's very difficult. You cannot compress, and you have to stop the bleeding. So sometimes you have to go in. Okay, if you can see from the picture here on the right side, this is our patient. Actually, we did superficialization of the brachiobasic fistula. It bleeds after dialysis, basically. Post-op, patient was well, but patient had to go for dialysis. After dialysis, patient have bleeding. So actually, you can see here, when we open up the wound, there's active oozing from the wound. So for this patient, we have to go in, explore again to see where is the source of bleeding and try to cauterize the bleeding. Alhamdulillah, this patient we are able to stop the bleeding, and patient is recovering well after the second surgery. So that's why if you are in medical team, in nephrology team, sometimes we do ask heparin-free dialysis because complication like this that we like to avoid. It's very troublesome for us and even more troublesome for the patient. Okay. Second complication will be hematoma. It can be with or without active bleeding. If the hematoma is small and the fistula is still okay, still functioning, we don't need to go in. We just need to cover for infection. But if the hematoma is large and the trill is modified or absent, we need to do something. We have to go in and evacuate the hematoma. So if after we remove hematoma and the tree is not written, we have to do a second procedure, what we call thrombectomy. Remove the possible thrombus in the AVF. Because when it's hematoma, there will be compression toward the fistula. When compression, there will be altered in blood flow, in laminar blood flow. So what happened actually, there will be creation of thrombus inside the fistula. So we have to remove the thrombus to make sure the fistula is functioning again. You can see actually the disease post-op. You can see the picture on both right and left on the screen. Actually, it's a hematoma happen after dialysis. It can be quite extensive. It's like this, but alhamdulillah both are okay after resting the fistula. Okay, that's why sometimes after the kind of patient, the patient to have another line for dialysis first, rest the fistula first, and we assess again by ultrasound to see the patency of fistula, and we require the arrange for thrombectomy infection if there is compromised fistula. Next complication will be infection. I cannot stress more, basically, because we are dealing with something very delicate, very important. We are dealing with vessel. So during every procedure, even for us, before we start creating, and also during dialysis, we have to very careful and do a aseptic technique during each procedure to prevent this kind of infection. Because when infection occur, it will be very devastating to the patient. Sometimes the AVF cannot be salvageable, so patient had to be on catheter again, on dialysis catheter again, had to be, we had to create another fistula. So make sure we do a proper aseptic technique for patient with AVF. You can see here, the wound actually gaping with some discharge coming out and some slough on the wound. If it's just superficial surgical site infection, we don't need to do anything, but to involve the vessel, we have to go in. Sometimes we have to sacrifice the vessel, AVF. So another picture of patient with surgical site infection. You can see the wound escaping with some slough and some discharge from the wound. Actually, this is wound from the superficialization of the brachiobacilli fistula. Okay. The next complication that can occur after AVF creation, early complication, would be thrombosis. When does this occur? When there is inadequate blood flow to the fistula, that which leads to stasis and thrombosis. If you can remember our triads of stasis, hypercoagulability. So basically, this is what happened. Thrombosis will occur. Then, patient with inadequate venous runoff, for example, with history of subclavian catheter catheterization, patient with hypotensive episode, patient have multiple venous puncture with local fibrosis. This kind of patient that will develop thrombosis of the fistula. So that's why the intraoperative assessment is very crucial. If during the intraoperatively, the vein that we saw is more fibrotic, we can see visible thrombus. So basically, just avoid doing this kind of procedure on the patient. And during the flushing of the vein, usually for the procedure, one of the thing that we do, actually, we flush the vein to see whether there's resistance or to see whether there's a bad flow of blood or not. If there is, maybe we need to think of second procedure later on if there is stenosis and the AVF is not matured. Okay, so basically this is the thrombectomy that we perform on the patient. We can use one on method. We can use what we call Fogarty catheter. We insert the catheter inside the vein, inflate the balloon, and fish out the thrombus by pulling out the thrombus out from the vessel and see the blood flow afterwards. Okay. Then we proceed on the late complications of AVF creation. So the late complication, what can happen actually, the anosmotic pseudoaneurysm. So basically, we can see pulsatile mass appears at the incision site, the site that we created the fistula. Sometimes, most of the time, actually, septic process will be involved. So that's why it's important to make sure there is no chance for infections going to the fistula during any catheterization. So if there is anosmotic pseudoaneurysm, aspiration surgically is mandatory. It's required. We need to remove the pseudoaneurysm and need to rebuild or re-anastomose the arterial continuity. Okay. The second one will be the venous pseudoaneurysm. This is actually happen because of our method of cannulation of the fistula, because we used to do area puncture cannulation. You can see here on the picture on the right side, there's two aneurysm here, the below and the proximal one, proximal and distal one. Basically, this is the same puncture site that was performed on patient. So what happened? In time, the skin overlying the venous pseudoaneurysm will become thin. So patient will develop bleeding. So in this patient, actually patient bled from this area. So to control bleeding operation, and we go in, remove the pseudoaneurysm, ligate this fistula. So this one is not salvageable. Okay. The next complication will be stenosis. So venous stenosis is within the peri-anastomotic region, usually caused by high intraluminal pressure because of turbulent blood flow, vascular calcification, endothelial injury, and because of increased level of fibronectin. So for patients that come with stenosis, we have to do surgical intervention for the patient. It's either open surgery or endovascular surgery. But most of the time, patient might escape with just endovascular approach using a balloon dilatation, or even can put stent inside the stenosis part to enlarge back the stenotic part. So it's quite interesting picture you can see here on my screen. Basically, this patient actually have mega fistula. So you can see here the arterialized venous segment already become tortuous and large. It's like a snake on the patient's arm. Basically, what happened? There are stenosis proximal to this. It can be on the peripheral vein or it can be central vein. So most of the time, actually, because of central vein, patient have history of central vein cannulation before the surgery. Patient have subclavian cannulation. Patient have IJC cannulation, IJV cannulation before this. So what happened? The vein becomes stenosis. So because of high pressure of it, the vein distally become dilated tortuous. So in the patient, we have to do to see if and repair this mega fistula now. We try to make it smaller again. Because why? This is like a time bomb. You can see actually this is very dangerous because this is arterialized venous segment. If let's say patient accidentally knock something, involved in accident, patient will bleed to death because of this. Okay. All right. So next complication will be vascular access induced limb ischemia. There are many names for this kind of type of complication. You can see what we call Steele syndrome, dialysis access related Steele syndrome. A lot of name was given to this type of complication, but basically what happened actually because we created the anastomosis between the arterial vein, the distal part of the arm, the fingers, basically didn't receive enough that. So because of the, not enough blood flowing to the distal hand of this patient will develop symptoms. Okay, it can be as trivial as discomfort, pain, then it can be numbness, paralysis, and worse, it can be gangrenous of the hand. Okay, so you can see here from the picture, basically the right hand basically pink, the left hand already dusky, appeared bluish or purplish in color because of lack of arterial supply to the distal left hand. Okay, so that's why it is important for us to really go into details on risk factor that patient might develop Steele syndrome, the patient diabetes, any respiratory disease before this, and any lesion distal to anastomosis. Okay. So the manifestation, as mentioned before, can be cold extremity, rest pain, and gangrenous or ulceration. This is the grading of the Steele syndrome based on patient symptoms. Usually, stage 3 and 4, we do need to do something. We have to go in. We have to intervene in this stage 3, stage 4. But stage 1, stage 2, sometimes we might able to escape without any second intervention. And how to manage Steele syndrome? Actually, we have to think about patient limb before the fistula. If it's already gangrenous, we need to ligate the fistula. So we have to sacrifice the fistula. Okay. So apart from that, we have other technique that we do here in our hospital. to preserve the fistula, we can do a bending of the venous segment to reduce the blood flow to the arterialized venous segment. We can put prosthetic graft into position, and we can do other technique of reducing blood flow, increasing the blood flow to the distal part of the arm, such as drill or Rudy, distal revascularization, interval ligation. Okay. It is salvageable, but depend on the stage of the Still syndrome. Okay, so that's why maybe the healthcare role actually is to detect this early and refer appropriately to us if you think the patient have this kind of problem, this kind of complication, what we call Still syndrome. Based on the name, actually Still syndrome, the blood stolen into the other side. So the hand didn't receive the good arterial flow to the hand. Okay. Next complication will be the central venous occlusion. Okay. The incidence is about 2 to 40%. Usually, patient will come with swelling of the arms, face, or breast or chest, and we can see dilated superficial vein. So this patient have two actually. Basically, we patient have megafistula as well, and also central vein occlusion as well. This is similar to the stenosis that I mentioned before this. Okay. The treatment same. We can do central venoplasty or surgical bypass, and or we can do endovascular recanalization with stent graft to open up back the stenotic part, the occlusion part. Another picture here of our own patient. You can see the right hand is normal, but the left hand, you can see is very swollen. You can see up actually on the chest, actually there is multiple superficial vein dilatation. Which organ is affected? Basically the arms, the chest, or the neck. Basically depends on which level the stenosis happen, the occlusion happen. Okay. The last one actually not really people do notice about, actually heart failure. That's why for patient that come for assessment for AVF creation, we have to see whether the patient have any heart failure or not. Because when we do the anastomosis, some of the blood will be shunted from the left to the right side of circulation. So patient might have high output cardiac failure afterwards, after anastomosis. And patient, the symptom can be as early during the operation or afterwards, depending on the severity of patient heart failure. So that's why sometimes we do need to have assessment from the cardiology side to see what are the cardiac status of the patient, whether the patient is suitable or not for AVF creation. Okay, so if the patient develop this kind of complication, treatment will be ligation. We don't have any other choice. We have to ligate, because life is the highest priority compared to the fistula. Okay. So I think that's all for my presentation today. This is my reference for my presentation. Just a little bit on our introduction to our vascular unit, Department of Surgery. It is led by our own Mr. Ahmad Faizal bin Osman, our vascular surgeon. And now we have two specialists, Mr. Hisham, but he's currently on subspecial training for vascular surgery in HKL. And we have Mr. Fahmi in the vascular unit of Department of Surgery. Okay. If you input or any AVF related problem, you can refer to us to our CPD level 1 every Monday and Friday, our clinic. And our OT actually is every Tuesday and Thursday for local anesthesia case. For GA, every other Friday. Last time was every Friday, but because of after the COVID pandemic last time, we still are not really fully functioning yet. We only have about every other Friday, every 2 weekly for our OT. Okay, and we do have our own angio suite here. You can see angio suite here that we used to do our endovascular intervention for all patients that require endovascular approach of treatment. So with that, I thank you. Do any questions from the audience?
Thank you, Dr. Malik, for your talk for today. Apparently, there's no question from Zoom participant, and also I believe there's none from YouTube participant. Maybe we can wait for 5 minutes.
Okay, sure, right.
Dr. Malik, I think there's no. Oh, okay. There's one question from our Zoom participant. I believe Dr. Azwairi. Okay. Assalamualaikum, Dr. Malik. In what criteria do we do urgent thrombectomy for patient has acute thrombosis of AV fistula?
Okay, thank you, Dr. Azwairi, for that question. So basically, if you see the guideline, ESVS guideline, we can do thrombectomy up until 1 week of patient with thrombosis, because usually after 1 week, the thrombus will become organized. So that's our end of timeline. Then we cannot do anything. So for your question, what criteria do we do urgent thrombectomy? Actually, there's no rule of doing urgent thrombectomy. You do the thrombectomy at 3 in the morning. No, if patient is stable, there is on clinical examination, patient is stable, the fistula is still salvageable. Actually the thrombus is still soft, the thrombus length is not really long. Then we can plan for a proper thrombectomy session afterwards. Okay, does that answer your question, Dr. Azwairi?
Okay, I believe that's the only question we have for Dr. Malik, our speaker today. So if there's no other question, thank you again, Dr. Malik, for your sharing knowledge with us. Okay, I would like to remind our participant to register attendance for I attend and for medical practitioner to fill in the Google form through the link given in the chat box. With that, we end our CME today with Tasbih Kafarah and Suratul As. Thank you again, everyone. Assalamualaikum.